So I think one of the biggest confusion points for a squat is whether or not a butt wink is good or bad. I think ultimately what determines if it's good or bad is your intent. For example, if you are a power lifter and your sport is to barbell back squat and you have a butt wink occur, it's probably not as big of a deal in the sense that you need it for your sport. However, for the majority of us, the butt wink is telling us a lot of information. And once we understand what exactly it's telling us, we can understand that it's usually more on the compensatory side. There's usually unfavorable side effects that come from it, i.e. low back pain, i.e. poor movement patterns. And so we really want to start to address this. And in this video, I want to talk about three main strategies as to how we correct a butt wink. But before we can do that, we first need to discuss biomechanics. So before we can really address the butt wink, we need to go back and understand normal. I think a lot of people jump to the dysfunction, and when we do that, it's really hard to understand the why behind that dysfunction, or in this case, a butt wink. And if we don't know the why, then we don't know the what. What do we do to address it? So let's briefly go over what should happen during a normal squat as it relates to biomechanics and motion. So we can simplify it into three phases. First phase, external rotation. Second phase, internal rotation. Third and final phase, external rotation. Okay? So ER, IR, ER. What this usually corresponds to as it relates to motion, 0 to 60, 60 to 90, and then 90 to 120. Perfect. So we can say that for a normal squat to occur, if we're thinking a full range of motion to 120 degrees, our patients and clients need to move through external rotation, internal rotation, and back to external rotation. Okay. What does that look like as it relates to the pelvis? Well, ideally, it looks like a shape change that happens in external rotation, internal rotation, external rotation. When these relative motions between the pelvis and the femurs can occur, the femur can move in a straight line. And so we're going to have this nice vertical looking squat. Now, we have our ER, IR, ER. What's also coupled with that is counternutation, nutation, counternutation. So the sacrum and the pelvis and the femurs have to go through their relative motions. If this can happen, the person in front of you will have a nice looking vertical squat where you won't see the butt wink, right? So now let's talk about our butt wink. First, when do we typically see the butt wink occur? Normally, it's around the sticking point, and usually the sticking point is around 90 degrees. So once we start to approach higher amounts of hip flexion, so greater than 90 degrees, we usually see that butt wink happen. So what is the butt wink trying to accomplish? The butt wink is trying to accomplish external rotation. The patient or client cannot externally rotate in the correct way. In the external rotation, the counternutation of the sacrum way. So if it cannot do this, all it does is dump the whole structure. And so we see this posterior orientation of the pelvis. We see lumbar flexion. So the patient or client cannot achieve the relative motions here, so it finds it in the structures above, i.e. the lumbar spine. So the lumbar spine flexing, the whole structure dumping backwards, is a butt wink. And it's the brain's best attempt to regain external rotation. It can't do it in its normal means, so it has to go to the structure above, which is the lumbar spine. So we now understand normal biomechanics. We understand where in that normalcy the butt wink occurs, and we understand the why. So what do we have to do? All we have to do is get them good at what they're bad at. they are bad at finding external rotation. They don't have the space to do so. So we need to provide them strategies where they have a better starting point so they can capture their in-range external rotation. So as we discuss these three strategies, I want you to first remember that your assessment that you perform on your specific client is ultimately the best reference point. However, with that being said, there are some key principles that usually are apparent in a lot of these butt winkers, right? So the biggest principle is that these patients and clients are starting too far forward. When they start too far forward, they're going to end too soon, right? It makes sense. So what we want to do in all three of these strategies is work to get these patients and clients back. We need the rib cage back. We need the pelvis more back, so that way we can recapture our end range external rotation and perform our squat without the compensatory butt wink. So the first exercise is super simple. It's just a deep TRX heels elevated squat. Now I like this for a lot of reasons. One, it's really helpful for these patients and clients to be at end range to allow their bodies to naturally move into that end range external rotation that we're seeking. Next, I like the heels elevated position. Remember, a heels elevated position on a slant board or plates, if you don't have a slant board, is going to help recapture and really bias the body into more of a posterior pelvic tilt. Remember, we need more of a posterior pelvic tilt, aka counternutation of the sacrum, which is external rotation, to achieve that end range of a squat and not butt wink. Lastly, I like this as far as the TRX because we can hold it in a forward position, which allows the patient to naturally just move into that backwards posterior direction that we're ultimately looking to bias. So all we're doing here are breathing exercises where we're just going to go head down, hang out in this position. Make sure the patient or client isn't in a heels elevated off of the slant board position. We want to really maintain full contact, and then we're just breathing. We're hanging out, super simple. We're getting the patient or client accustomed to this deep end range external rotation. So the next exercise is a greater than 90-degree wall sit. Now, the wall sit is a great exercise to really use the wall as a constraint. Remember, we are trying to pick up relative motions of the pelvis. This means it can go through its ER, IR, and then back to ER. So when we have the wall here, it's a nice way to act as a constraint to not let the whole pelvis dump and the lumbar spine go into flexion, like we see with the butt wink. And again, it allows that patient or client to feel what that feels like. So it's a great way, but I would say to really be successful at this, we need a ball between the knees. You don't need to absolutely crush the ball, but what we need to do is to use the ball as a reference for the legs or the femurs to remain in a straight position. Remember, when the legs stay straight, the pelvis is going through more of its relative ER, IR, ER motions. So all we're going to do is go into a wall sit position, ball between the knees. We're going to go into a slight tuck just to get a neutral spine, nothing crazy. And then as we go down, cue your patient that as you slide down, you need to feel your low back pretty much on the wall. You need to continue to push the knees forward, and you need to make sure that you don't come off the wall up top, aka another way to find lumbar flexion. And once we're in this position, we're going to reach and make sure we stay on the wall. Now the reach is really nice because as we're reaching, it's biasing that posterior direction that we are trying to recapture. So all I would do is I'd go 4 breaths in this position, open hand position, reaching while maintaining contact, 4 breaths, and then come out of that and repeat if needed. The last exercise is a front foot elevated split squat. Now this would be the most challenging of the 3, and it's a great one because it's going to allow us to go past that 90-degree mark, but really in a way that provides a lot of awareness to the patient or client. Now biomechanically, remember, as we start to go down into the descending phase of a lunge, we're moving towards internal rotation and then out of it and back into our external rotation before we actually then come back up. So when we go in a heels elevated position, it's going to naturally push your body weight back. Remember, that's the end goal here. So starting in more of a back position, you can see as I start, I'm more at a negative shin angle, negative represented by the knee being behind the ankle. And this is required to really go and start in that starting position of our first phase of ER. Then we move to IR and then our last phase of ER. Now, the nice thing about the front foot elevated split squat, besides the posterior shift, is that because we're on an elevated surface, it really allows us to go deep below that 90-degree mark or above, whichever way you're looking at it. So all we're going to do in this is to really cue our patient to make sure that they are in a neutral position, right? So we're not trying to be in an anterior pelvic tilt, and definitely we don't want to see them do the butt wink. Again, all of these positions that we're putting our patients and clients in makes it really hard for them to compensate, and it biases more of the relative motions that we need to pick up to not butt wink during the squat. So all we're going to do from here, make sure we're very vertical on this heel, not down low, because that is going to drive more of this escalator motion. We are trying to be just like an elevator, right? So we're going to be straight vertically on this heel. We're going to go straight down. You're going to hang out, take a breath, and then back up. So if you want to capture it with the breathing, inhale on the way down. Hang out, exhale coming up. Notice how my knee continues to travel forward. As I go down, the knee's pushing forward, 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 but I'm staying slightly back. And then when I come up, the knee goes back. A lot of times patients and clients will go here and then they actually kind of cave back. So we've got to make sure forward motion of the knee, straight down, achieve that greater than 90 degrees of hip flexion, and then back up.